All right, good afternoon, everybody. We're going to go ahead and get started as everybody is joining in. So thank you for joining us for today's American Ambulance Association webinar, the 2023 Medicare update presented by Brian Werfel, the AAA's Medicare consultant. Before we go ahead and hand it over to Brian to get started, just a couple housekeeping items. So today's webinar is being recorded. The recorded version, as well as the PowerPoint slides, will be available on the AAA's on-demand store tomorrow morning. So if anybody from your service would like to watch the webinar and wasn't able to join us today, be sure to check out the on-demand version on the AAA's website. If you have any questions throughout today's presentation, you can go ahead and use the Q&A feature on your menu. We've disabled the chat, so please use the Q&A feature. Brian will try to get to your questions throughout today's presentation or at a brief Q&A session at the end of today's presentation. And with that, I'll go ahead and turn it over to Brian to get us started. Thanks, Brian.
Thank you. All right. Thank you, Megan, and good afternoon to everyone. Good morning to those of you that are joining us on the West Coast. This is, as Megan indicated, our first quarter wrap-up Medicare update. And it's, again, time to coincide with the release of our reference manual, which I hope all of you will download soon. Just a few housekeeping items before we kick things off. This session is for informational purposes only, and it should not be relied upon for legal, financial, or accounting advice. If you require any of those professional services, we do ask you or recommend that you seek the assistance of a licensed practitioner in your jurisdiction. First topic I just want to talk about is just to recap where we are with the fee schedule itself. In 2023, we saw the largest inflation update since the adoption of the fee schedule. In fact, since the adoption of the Medicare program itself, 8.7%. So that is a 9.1% change in the consumer price index for urban consumers over the 12-month period that ended in June of 2022. Subtracted from that is the multi-factor productivity adjustment, which was 0.4%, and that gives us our 8.7% increase. This is, again, the largest single-year increase in the program's history for ambulance services, and it is also the largest single-year increase over 2022 when it was 5.1%, which at the time was the largest inflation update in Medicare's coverage of ambulance services. So what you're seeing on this chart is the blue line is the change in the CPI urban, the yellow line is the multi-factor productivity adjustment, and the resultant AIF is in gray. So what you're seeing is that the ultimate AIF, the inflation adjustment, has traded in a fairly narrow band since 2011 when the MFP was put into place. It's generally been somewhere around 2%, consistent with the Fed's target inflation rate of 2%. However, since 2021, what you've seen is a dramatic increase in inflation. And while this is tapering off somewhat, it is expected to be significantly higher than that 2% target rate for, depending on whose projections you look at, either the next 4 or 5 years for sure. Now, one thing that should be mentioned is the last 3 months of the 2022 measuring period, so the second quarter of 2022, had a particular spike in inflation. And as a result, we got the benefit of that included in the AIF for this year. But what you're going to see is that that's now resulted in the measured rate of inflation being significantly lower during what will be our 2024 inflation adjustment measurement period. Over those first 8 months, inflation is only 1.5%. So this will likely mean a significant reduction in the AIF in 2024. Now, if your options are to get a big spike and then a smaller increase the next year, or vice versa, you'd rather get the big spike in the first year because it grows the base from which inflation is adjusted going forward. So we did benefit from that temporary spike in inflation in terms of our rates for 2023, but I don't want people to think that it's likely going to be next year's number is going to be anywhere near what we saw this year. So that's a piece of what goes into our fee schedule. The next piece is all of the temporary add-ons for ground ambulance. Specifically here, we're talking about the 2% increase for urban, the 3% increase for rural, and the 22.6% increase, and that's over and above the rural rate itself for super rural areas. Those were scheduled to expire at the end of 2022, but on December 29th, the Consolidated Appropriations Act passed and extended them for another 2 years. So for both 2023 and 2024, those 2%, 3%, and super rural bonuses will be built into the fee schedule. Now, we do have sequestration taking 2% off that number. That was extended as part of that same deal in order to pay for some of the spending in the Appropriations Act. So the current sequestration will now run through 2032. Given what's happened, that was initially supposed to be a 10-year sequestration, which would have expired in 2022. But what ends up happening is every time Congress passes new legislation, one way they can pay for it is by adding years to the back of the sequester. So at this point, it's scheduled to expire in 2032, but it's starting to look more and more like a permanent piece of this. Now, in addition to that sequester, there was an additional 4% cut in Medicare reimbursements that was going to be triggered by what's called the pay-go rules or pay-as-you-go rules. So what had happened here was when the Biden infrastructure plan passed in 2021, they forgot to exempt, or they decided not to exempt it from the pay-go rules. As a result, because the deficit increased, that triggered an automatic 4% cut in Medicare payments that would have gone into effect in 2023, but as part of this most recent legislation, they delayed that implementation until 2025. So where things stand now is we get our 2% increase for urban, 3% for rural, and super rural bonuses. From that number, though, a 2% sequester is taken out of Medicare's portion of its allowable. So the 80% of the allowable that it usually pays, 2% is taken off from that. So that amounts to, functionally speaking, a 1.6% reduction. So up 2%, down 1.6% is still up. But as things are scheduled now, in 2025, we face our version of a financial cliff. Unless Congress acts, the existing 2%, 3%, and super rural bonuses will expire. The current 2% sequestration will still be in effect, and an additional 4% Medicare cut will go into effect. Will that happen? Difficult to say, but for now, we do face this sort of financial cliff in 2025. Now, by then, MedPAC will have issued its first report, and Congress might be in a position to rethink the fee schedule at large. But I just want everyone to know that for the next 2 years, we're fine. It's business as usual. But starting in 2025, if something doesn't happen, things will change. All right, now turning to just some historical payment data. What you're looking at here is a chart of total Medicare payments for Part B. And what you're going to see is that starting around 2010, we approached the $4 or $5 billion number. I apologize, my camera is, my face is covering the numbers. But we approached the $5 billion number for Part B payments. But we never quite pierced through that number, and that is for a number of reasons. There have been several changes to the fee schedule during the ensuing 12 years, each of which has offset the amounts that our payments would have increased due to inflation. And at the same time, the volumes have gone up, but those cuts in reimbursement have offset the additional dollars. So starting in 2010, you had the move to fractional mileage as opposed to rounding up to the nearest, the next whole number. And then you had a number of program integrity actions, most notably the implementation of the demonstration project for prior authorization for repetitive trips, which then went national in 2020. And also what you're seeing is the impact of COVID at the back end of that between 2019 and 2020. These are the national numbers for Part B. There is about anywhere between 250 and 300 million additional dollars that are paid for ambulance services through the Part A program. But what you're seeing is that our total payments have largely been stagnant since 2010. So, when people talk about growth in the Medicare program, our issue is not the problem. If anything, we've gone backwards in terms of total reimbursement. Putting that in actual dollars paid, and these are 2021 numbers. So these are the allowed amounts and then the total dollars paid. And then we can then compare those to 2020 numbers. Now, normally this sort of analysis year-over-year changes would be helpful in just spotting some trends. For instance, if you go back and track the number of allowed services for BLS non-emergency, you can see quite clearly the impact of prior authorization. However, 2021 is comparing to 2020, which is the COVID year. So what you're going to see is some fairly wild swings here. So for instance, the ALS emergency is up 13% in terms of allowed services. That's really less a change from the, well, it's a reflection of the dramatic decrease that occurred in the start of 2021. The start of 2020 as the pandemic took impact, and then things sort of normalizing. If you go back and add a third year, 2019, to the analysis, things have largely snapped back to where they were pre-pandemic. So I wouldn't attach too much significance to the percentages on the right, but the total dollars are there. On turning now to COVID itself. So at the end of January, the White House announced that it would no longer extend the temporary, the public health emergency for COVID. So what that means is that many of the waivers and other program flexibilities that were put in place during COVID will expire on May 11th. So you'll need to adjust to the extent you elected to take advantage of these flexibilities and or waivers. You'll need to make future adjustments in the next month just to make sure that things go back to the way they were. So among the things that will be impacted is the expansion of the approved destination list. Now, this is not a waiver. In 2020, CMS passed a final rule amending its regulations to add new language that said that during a public health emergency, it would expand the list of acceptable destinations, covered destinations, to include that list that's on that left there. Most notably, that includes urgent care facilities on the pre-hospital side and physicians' offices. This is for both emergencies and non-emergencies. Again, the idea was that in allowing individuals to go by ambulance to non-traditional healthcare providers or traditionally non-covered healthcare providers, it would decrease overcrowding in the ERs, which was important in the early days of the pandemic when we were worried about running out of hospital capacity. So this is not a waiver per se, it's rather just an amendment to the regulations, but when the public health emergency expires, this will no longer apply to us. So come May 12th, you will go back to the normal standard list of covered destinations. The treatment in place waiver was put in place in March of 2021, so it's now 2 years old. It was a very limited waiver that would allow you to be paid for treatment at the scene if certain conditions were met. The most important of those conditions is a but-for analysis. And by that, what I mean is it's not any time you treat the patient at the scene. It's limited to those situations where you would normally have transported the patient, but given protocol changes that were required to or put in place to deal with COVID, you were no longer required to transport them, or you were permitted to treat them in place. So in other words, it's but for a change in your protocols, you would have transported them. Now you don't, and you treat them in place. So because of that condition, that it required an active change in protocols, it's a very limited waiver, because many of you are already permitted to treat patients in place when it's clinically appropriate. So you can see how limited it is in some of the correspondence. So in March of 2022, so 1 year after it went into effect, Congress, or Representative Cindy Axne, wrote to CMS asking about the payments themselves. And in response, what CMS indicated is that during the first 6 months of the treatment in place program, it only paid about 10,000 claims and only about $3.6 million total. So annualizing that, it would be about 20,000 or so claims and about $7 million. So 7 million out of 5 billion is a very small percentage. So this was never really the panacea that it was sort of hoped to be. It's very situational specific. Probably the biggest waiver in terms of actual day-to-day operations focused on the patient's signature requirements. So what CMS did here was to say that for not just ambulance, but all face-to-face healthcare encounters, in lieu of the patient's actual signature, you could substitute the patient's verbal consent to the extent it would be impractical to decontaminate whatever it is that the patient is signing. And in our case, frequently that is an electronic tablet. There are limits to what we can do to decontaminate those. Some of the cleansers are quite astringent and damage the electronics. So what CMS was saying is, you could ask the patient, do I have your consent to the submission of this claim? They would say yes, and then the crew was supposed to document that they obtained the patient's verbal consent. That would satisfy the signature requirement as if it were the patient's actual signature. This will go away on May 11th. What that means is that we need to go back to the old process, which is the starting point is an actual signature from the patient. If that can't be obtained, then we need to document why the patient couldn't sign, and then move on to one of the alternative signatures. As a reminder, many of your crews, based at least in my experience, have gotten in the habit of writing things like biohazardous risk or contamination risk, etc. Not because there's an actual real concern about contamination, so much as they simply don't want to ask patients for signatures. So this has become sort of their easy button. If you've elected to give the crews this option, you need to start thinking now, in my opinion, about how to wean them off this option, because it will take time. But starting May 12th, verbal consents will no longer be an acceptable alternative to the patient's actual signature. They've also waived a lot of the ambulance staffing and license requirements. Now, it's wordy, but in order to understand what's going on here, what CMS has basically said is, our requirement is that you follow the state's licensing and staffing requirements. So to the extent your state has waived certain licensing requirements, for instance, maybe it was the case that the vehicle had to be staffed by 2 EMTs, but they now allow a certified vehicle operator or an emergency medical responder as the second crew member. As long as the state, you met the state requirement, you would have met the CMS requirement. Once we eliminate this waiver, we will go back to the old requirement, which is, generally speaking, at least 1 EMT for a basic life support truck and at least 1 paramedic or EMT intermediate for an ALS licensed truck. Just circling back to a question Christina asked, the question is whether or not the destination modifier P will no longer be reimbursable after May 11th. And she notes that if so, we have a lot of patients who are picked up from a clinic provider's office. Which destination modifier would you suggest? So Christina, it's not that the P modifier is no longer reimbursable after May 11th. Under certain circumstances, it still would be reimbursable. It may be bundled to a facility. So for instance, a patient leaving a skilled nursing facility to go to a physician's office during the first 100 days of their SNF stay, that was always a covered service. It was just bundled to the SNF, meaning we would bill the SNF. What this is changing is the situation where, for instance, that patient after their first 100 days in a skilled nursing facility is going to a doctor's office. Under the waiver or the expanded destination list, that was per se covered. So N to P after the first 100 days of a SNF stay was separately payable by Part B. Now you would apply the reasonableness test for those N to P trips after the first 100 days. And that says it's covered when a patient starts in a facility and goes to a physician's office to the extent it's cheaper to bring the patient to the service than the service to the patient. However, patients that are coming from residences or assisting living facilities and going to a physician's office will revert back to being non-covered transports, meaning you would bill the patient directly. I am a bit confused, Christina, so maybe it might be helpful if you just clarify, but this would not affect the patients that are being picked up from a clinician's or a provider or a physician's office. So if you pick the patient up at a physician's office and take them to the hospital, that transport would still meet the origin and destination requirements because they cover from any point of origin to a hospital. So this is really the P as a destination modifier would be impacted by this. So I hope that answers it, but if not, please feel free to just add whatever additional information you think would be helpful. Moving on, this one's a bit of a misnomer. CMS indicated that during the public health emergency, it wouldn't review for compliance with the appropriate signature requirements, the PCS form, absent evidence of fraud and abuse. This was never intended to be a waiver of the PCS requirement. I know that there were some people out there that, sort of opined that that was the case when it was first passed. It never quite made sense to me because there's really nothing about the pandemic that would have prevented, for instance, doctors from faxing over the PCS form to the ambulance company. All CMS was saying is that absent fraud or abuse, they wouldn't audit for the PCS form. But in fairness, the PCS form is used to curb fraud and abuse, meaning if they're auditing for it, they suspect possible fraud or abuse. So it was somewhat circular, but I would not treat the PCS form as negotiable, either during the public health emergency or after it. It is the primary tool by which auditors use to validate medical necessity for non-emergencies, and we should be complying with it whenever possible. Keep in mind, though, of course, that there is an exception that would allow you, at least for non-repetitive patients, to submit the claim after 21 days, provided that you've documented your attempts to get that PCS form, through proof of mailing or whatever. The Provider Relief Fund, just as a reminder, the last report for any payments that were received in period 4, so that would have been the second half of 2021. Those reports were due March 31st of this year. This is where you're reporting on how you use the funds. And either you could use it to offset increased expenses that were directly attributable to the pandemic or your ability to operate in a pandemic environment, or to lost revenue from the pandemic itself. One of the things that I'm finding is a lot of companies are realizing that the amounts of money they received, especially those companies in rural areas that got a targeted rural distribution, may not have enough increased expenses and or lost revenues to offset those provider relief funds. And they're finding that they actually may have to give the money back. So if that was your situation, you are now within the 30 to 60 day period in which you need to send that money back based on how your reports went. If you didn't file a report because you forgot and you received money during that July 2021 to December of 2021 period, be on the lookout for a letter from HHS asking you for the money back. So, just make sure that if you think you might need to refund that money, that it's there when they ask for it. One question was about the Medicare rate calculator, and will it be available soon? It is my understanding that it is on the AAA's website. The calculator is complete. It should be on the website. I'll just confirm that it's live on the website. One word of warning when you use the calculator is it is accurate and it will give you the correct rates for your area. But unfortunately, there is a little bit of a bug if you're in a rural area and you're trying to calculate the total mileage payment when you go more than 18 miles. It is incorrectly applying the bonus for the first 17 rural miles to every mile from 18 onwards. So just be mindful of that. I know most people don't use it to calculate mileage rates. We're more looking at base rates there. It is correct on the base rates. I know we've talked about it quite a bit, but ambulance cost data has been one of those topics that has really grabbed the industry's attention, especially now as we are in the first reporting period. So just to briefly run through the timelines here, and to fast forward through the initial plan and through the revised version that came about as a result of the pandemic, there are currently 2 tranches for providers to report in. Those that were selected for either years 1 or 2 will report during the first data collection period. Those that were picked in years 3 and 4 will report in the second collection period. And now we have to define our terms. The data collection period is the calendar year. So for those of you that are year 1 or year 2 participants, your data collection period runs from January 1st, 2022 and expired on December 31st, 2022. Within that, you have to select a 12-month period on which you will report your data or collect and then report your data. So you can either pick that same calendar year, meaning the 2022 calendar year, or you can pick your fiscal year. If you pick your fiscal year, you would pick the fiscal year that started during the data collection period. So if you're a year 1 or year 2 participant, your fiscal year will be the fiscal year of your entity that starts during the 2022 calendar year. Once you've collected data over a 12-month period, you now enter the reporting period. That is 5 months after the close of your 12-month collection period. So if you elected a calendar year, you closed your calendar year if you were year 1 or year 2 on December 31st of 2022. You have 5 months to submit your report, meaning by the end of May 2023. If you elected a fiscal year, and let's say your fiscal year runs from July to June, you would start your 12-month collection period on July 1st, 2022, end it on June 30th, 2023, and report 5 months later, meaning by the end of November 2023. And then you will repeat that process if you're a year 3 or year 4 provider. Dawn, I know you had a question, but if you wouldn't mind just typing it into the Q&A period. Unfortunately, we don't have the ability to open up phone lines for people to ask a question live. So please type in your question. I'm happy to get to it. If you are in the reporting period, just make sure you're looking at the correct version of the ground ambulance data collection instrument. The most recent version is the one that came out in November of 2022. And there are a ton of resources out there to help you through this process. So on the left-hand side of the screen, you'll see the ambulance cost education. That's the AAA's cost data group. You'll see all of our resources. And then on the right, you'll see the CMS data, the CMS resources. So among the CMS resources that I think are worth taking a look at are certainly the data collection instrument itself, the printed version. Now, do keep in mind that it will look a little bit different than the portal itself that you'll use to report your data, the online portal. That's because the data collection instrument contains skip logic. So depending on the answers to earlier questions, certain items that may appear in the printed version may be suppressed for yours service. So for instance, if you tell them you do not use volunteer labor, they won't ask you questions about volunteer labor on the online portal, but they will show up in the printable version. And then what's very helpful is the FAQs. So that'll address certain specific situations. You know, for instance, how would you allocate the percentage of your facilities if you're a shared service model? Maybe you're a fire department. How would you allocate the physical space between the fire engines and the ambulances? Things like that, right? The hardship exemption request form is there, although I will tell you now it is highly, highly improbable that anyone that fails to submit their report will qualify for a hardship. It's not intended to be, it would be difficult. It's not intended to be, I really don't want to take that 10% penalty. I just forgot to do it. It's really more along the lines of a fire burned down our building and all the records are lost. So acts of God. So barring those, most people will either have to submit their reports or accept the 10% penalty. From the AAA's perspective, we would strongly encourage, and we really do hope that everyone here does submit a report for two reasons. We can understand the potential attractiveness of not digging into this or leaning into this and just taking the 10% penalty, especially if you're a relatively small service and you can't allocate the manpower or the resources to get it done. But our argument would be that that would likely mean you are exactly the type of service that is going to be disproportionately likely to have higher average costs. And if every one of those low volume rural services elects just to take the 10% penalty, we believe that the data itself could be skewed in the aggregate, and that will weaken the argument for additional resources. Again, keep in mind from the industry's perspective, our hope is that once CMS has the cost data in place, that analysis will show that A, Medicare is not covering our costs, and that B, the total pie needs to grow. We can have debates over how to grow the pie, but for now, step one is just to grow the pie as large as possible. In terms of the AAA and the ACE resources, on there, you'll see a lot of on-demand webinars. In particular, we have webinars devoted to each section of the data collection instrument. So those are intended to allow you to get in there and just really dive deep into each topic so that you can get through those particular sections. So in that, we will, for instance, address specific questions that have just come up on multiple occasions. One of the questions that popped up is whether the portal itself is on the CMS website. It is. When you click on the CMS data collection web page, the home screen, in the top right-hand corner will be a link to the portal itself. Now, you do need to register for the portal, and there are a number of steps that are needed. They're not particularly difficult, but they can be a little bit confusing if you're not prepared for it. And they do take some time. So my strong suggestion would be not to wait until the last minute on this thing. If you have your data today, I would be submitting it now. I would not be waiting until the end of May. But if you have additional questions on the specifics of cost data, absolutely check out those ACE resources. We have a ton of webinars out there that will help you sort of understand that process. And then, of course, we have a helpline. If there are any specific questions, it's hello@ambulance.org. That goes to a group of individuals, all of whom are qualified to answer the questions. And we make it a point to try and get back to everyone within 24 hours of when you ask those questions. So we encourage you to make good advantage of all of those resources and get through that process. There's also the, scannable code there to go directly to our landing page and to register for the Amber software. That is our sort of, it's a software application that is derived from the CMS portal, but it is intended to be much more user-friendly for you. It will also allow you to enter your data over time and in different sections, with the goal of ultimately then being able to, from there, print it out and then just manually enter each of the data fields directly into the CMS portal. Unfortunately, there's not a direct ability to transfer your data from Amber into CMS through an API. We asked for it, but CMS is hesitant to give anyone access to the tool, to their portal. All right, so what else is new in the Medicare world? So the first is, as part of its end of year 2022 final rule for 2023, this is in particular the outpatient hospital payment rule, CMS did provide some clarifications related to what it's calling rural emergency hospitals. Specifically for us, it indicated that they are a covered destination for ground ambulance transports. And then it clarified that ambulance services that are furnished by these rural emergency hospitals will be paid under the Medicare ambulance fee schedule. So that was in response to questions as to whether or not they would be eligible for reasonable cost reimbursement, similar to critical access hospitals. No, they will not be. They will be paid under the fee schedule unless they also happen to qualify as a critical access hospital and meet the additional requirement that their ambulance service be the only licensed ambulance service within 35 miles of the hospital, excluding state borders. CMS also made a change to the regulatory language for the PCS form for non-repetitive patients. Sorry, for repetitive patients, excuse me. So the previous regulation language is on the left, the new regulation language is on the right. It's not entirely clear what the purpose of this requirement is. If you go by CMS's explanation in its preamble, they are adding some clarifying language about what types of records can be used to support medical necessity, intended to assist their MACs with prior authorization. I'm inclined not to read too much into this and just take CMS's explanation on its face. But honestly, when you read through the rule itself and certainly the preamble, it does seem that CMS is frankly a bit confused as to what the issue is. Importantly, though, it is not the case that a PCS alone establishes medical necessity for the ambulance. So CMS gave itself the right several years ago and continues to have the right to look beyond the PCS form if it believes that either A, the PCS form doesn't provide enough information, or B, it questions the accuracy of the information on the PCS form. So one common example where they may question that accuracy is the question of whether or not a patient is bed confined. So in other words, just because a PCS says the patient is bed confined doesn't preclude CMS from looking at additional documentation that discusses or documents the patient's ability to sit, stand, or walk. So a good example of that would be the minimum data set from a skilled nursing facility. So one way to read this new language is to say that it gives us the ability to submit that MDS when it supports the PCS, and we can point to this language as requiring the MAC to at least consider it. But conversely, it also gives CMS the right to look beyond the PCS form to that MDS if there's a conflict between the two. So unclear where they're really going with that. Another unintended consequence, I believe, is a proposed rule regarding the return of overpayments. So under the existing rule, a provider must refund an overpayment within 60 days of the date on which the overpayment was identified. So if you identify an overpayment today, you have 60 days to refund the money. If you don't refund the money within that 60-day period, that overpayment becomes an obligation under the False Claims Act And then it would open you up to False Claims Act liability. It would also open you up to potential QI-TAM actions by employees. So that part of the rule is not changing. Once an overpayment is identified, you have 60 days to return it. What is changing is there was language that indicated that for those purposes, an overpayment would not be considered to be identified unless and until you can quantify the amount of the overpayment. Now, in some cases, this will be easy, right? Medicare paid a claim twice. You know they should have only paid it once. You know the amount of the overpayment. I find that today I have 60 days to refund it. But there are some instances where you know you've been overpaid, but you don't know which particular claims it impacts. And as a result, you can't identify the amount of the overpayment, which would make refunding it difficult. So for instance, if I come to you as your billing manager and say, when I uploaded the latest update from our billing vendor, I accidentally crosswalked ALS emergency to the ALS2 HCPCS code. I checked and I'm certain if someone goes to bill ALS emergency, it will send the claim with the HCPCS code A0433, which corresponds to ALS2, and we will be paid too much. Now, as the CEO of this organization, you will say to me, how many claims did we bill incorrectly? And I can say, look, we billed 1,000 claims last year with A0433. I don't know how many of those were correct or not. I would need to investigate it, right? But the concern here is that, has that overpayment been identified? Under the old rules, no. I would have a reasonable period of time to go back, look at all 1,000 of those claims, determine which ones were correctly billed ALS2, which ones were incorrectly billed ALS2, quantify the amount Medicare paid for the incorrect ones, and then I would have 60 days to make the refund. Under this new rule, it's unclear when that 60-day time period starts. Now, one thing to understand about this is CMS was not attempting, this sounds like what I just described, sounds like CMS is making its rule more strict, meaning adverse to us. That's absolutely not their intent. Rather, CMS had to respond to a court case that indicated that the previous rule, which indicated that the overpayment is once you're overpaid, you have to refund it, failed to account for situations where you simply had an overpayment, but it was mere negligence that you were unaware of it. And negligence cannot be the basis of liability under the False Claims Act. So courts struck that down for Medicare Advantage providers. There's a big thing going on with a lot of the Medicare Advantage providers getting sued by the DOJ and or settling with the OIG because they've been upcoding the severity of patients to get higher payments for each patient. One of them was challenged in court by United Healthcare, and the judge said that mere negligence cannot be the basis of a False Claims Act. So what CMS is doing is going back to its original language that it first proposed in 2012, which says that the overpayment can become an obligation under the False Claims Act to the extent the provider knowingly receives and retains the overpayment. And that can mean actual knowledge and constructive knowledge, meaning recklessness or willful disregard that an overpayment exists. So I come to you and say, I think we may have been overpaid for A0433, and you say, don't look, whatever you do, don't look, I don't want to know. That would be willful ignorance, right? But in attempting to dial back the situations in which can impose False Claims Act liability, it eliminated the quantification concept that triggers the 60-day period. It's probably an oversight. I know a lot of healthcare providers across all industries have commented on it, and it's likely the sort of thing that CMS will address in the final rule. But I do want everyone to be aware of it. Taking a side note, just to answer a couple of questions about PCS forms. The first asks, for a repetitive PCS, does it have to be a physician that signs, or can a physician's assistant or nurse practitioner sign? So for repetitive patients, meaning patients that will be going 3 or more times for the same service in either a 10-day period or once a week for 3 straight weeks, so repetitive, dialysis is a common example, only a physician can sign. It cannot be a physician's assistant or a nurse practitioner. For non-repetitive patients, the physician can sign, but so can a nurse practitioner, a physician's assistant, a clinical nurse specialist, and a whole bunch of other individuals, up to and including case managers and social workers. The second question, well, not question, says we're having issues when we bill without a PCS form under the 21-day alternative. So we've attempted to get the PCS form and have the certificate of mailing proving that we attempted it. The problem happens on appeals and reconsiderations of defined claims. We are informed that without the PCS, the claim will not be looked at. Eric, I'm not sure who's telling you that, but they're simply wrong on the rules and the law. So you may just have to keep appealing, but at the ALJ level, they will look at the regulation. If you've met the 21-day alternative, and they believe that medical necessity is otherwise evident, they should pay the claim. But no, I mean, you sometimes run into people at the max that review these claims that simply don't understand the rules. One thing I will say, though, is if this is in the prior authorization regime, meaning for repetitive patients, they are correct, in part because, again, it must be signed by a physician. There is no 21-day alternative for repetitive patients. So I'm wondering if that may be the issue. So just to clarify, the 21-day, the alternative to getting a PCS form is only for non-repetitive patients. If that's the case, appeal up to the ALJ and they will look at the regulation. And if you've met the requirements, they will pay the claim. If we're talking about prior authorization, which is for repetitive patients, then you must get it signed by a physician, no exceptions. All right, so moving on to the Medicare appeals backlog. One of the things we saw is this dramatic increase in the length of appeals. So at one point in, I believe it was right around 2018, it was not uncommon for there to be a 6-year delay in getting an ALJ hearing, meaning if you filed in 2018, at the time you were looking at 6 years. So this is the average ALJ processing times. This is looking backwards from the date of the ALJ hearing itself to how much earlier the appeal was filed. But what ended up happening was there was a court case in the federal district for the District of Columbia, where HHS was ordered to eliminate the backlog over a 3-year period, and they've done so through a number of initiatives, including settlement conference facilitation, mass settlements, et cetera. The key point is, as of today, we are back to no ALJ backlog, meaning the statutory and regulatory timelines apply. So what that means is if you file for an ALJ hearing today, they will schedule that hearing within 60 days. So that now makes it a viable alternative. As opposed to, when you were waiting 6 years, a lot of times we would just write off the claims because who wants to wait 6 years to hear an ALJ appeal? But today we are back to 60 days. So if you have a situation sort of like where Eric is at, where there, you just can't make any progress with either the MAC or the QUIC, the second level of appeal, feel free to get to that ALJ. They will absolutely look at the regulation. That is also the first opportunity for you to have a discussion with anyone about the claim. And that is, in my opinion, likely the best place to get it paid. Turning to some, before we turn to some compliance issues, one more question on the PCS form. So for clarification on repetitive patients, does this go by the HCPCS code? Or is a patient considered repetitive by them going to the same destination, having the same procedure done? So good question, Deborah. It should be for the same procedure. So for instance, a patient goes to and from dialysis Monday, Wednesday, Friday. First day is Monday, they're not repetitive. Second day is Wednesday, they are not repetitive. When they complete the round trip on Friday, they become repetitive, meaning next week on Monday, when they go again, the rules kick in and a PCS form must be signed by a physician. You must go through prior authorization, etc. The non-repetitive rules apply to the first three claims. However, while that's the coverage rules, the max edit based on the modifiers. They don't have the ability to look at the individual procedures that the patient goes for. So because there are different modifiers for dialysis, it's easy for them to segregate those out. But a patient that has 3 round trips to a hospital out of their residence, even if all 3 are for different procedures, would likely be flagged by the MAC as repetitive, meaning you would have to go through the prior authorization process. However, in that prior authorization process, you can submit documentation that shows that the patient, that it's not the same service. You also have the option, of course, of just making the argument for medical necessity at that point and getting an approval. My guess is if they've gone to 3 different procedures in the hospital in one 10-day period, they're likely going to have several more trips to the hospital during the ensuing weeks, and you may even benefit from getting prior authorization. So turning now to some compliance matters. I think we skipped here. So the first one I want to highlight is the supplemental medical review contractor, which is Noridian, has been fairly active in the last few months auditing providers. Now, the supplemental medical review contractor is different than the old program safeguard contractors, which changed their names first to the zone program integrity contractors, ZPICs, and then to the unified program integrity contractors, UPICs. UPICs can look at anything and frequently do look at medical necessity. The supplemental medical review contractor, again, Noridian, tends to focus on discrete issues that have been identified as areas of particular program vulnerability. So if you recall a few years back, the OIG went after providers for incorrectly billing Medicare when they should have been billing the SNF under a Part A consolidated billing bundle. The OIG limited its activities to providers that were over the $100,000 threshold. Under the $100,000 threshold, they handed it off to Noridian as the SMRC to review. So Noridian did review several dozen providers during that 2017, 18, 19 period. And then they sort of went away for a few years. Well, they're back fairly aggressively these days. It looks like what they're focused on is the mileage. Specifically, they're looking at whether or not the patient was transported to the closest appropriate facility, and therefore whether all of the mileage should be paid. Now, one theory is that they are operating off of the OIG's report in 2015 on what it identified as 7 questionable billing practices. One of those billing practices was large amounts of mileage in urban areas. So what they determined is that, at the 95th percentile, urban mileage is something like 10 to 14 miles, but they identified a small subset of providers that routinely billed in an urban area for 30 or more miles. It looks like they're focused on urban mileage at this point. Now, they're not necessarily wedded to the 30-mile mark, but it does look like that's what they're looking at, is to see whether or not the mileage that you build is either a typographical error. You meant to bill 3.0, but you forgot the decimal place and ended up billing 30. Or are we bypassing the closest appropriate facility? Now, that dovetails with something WPS has done first in Missouri, and now it's looking to expand it into other states like Michigan and Indiana, where it is focused on locality. So the WPS policy is that it will pay to the nearest appropriate facility and any other facility that falls within 5 miles of the nearest appropriate facility. So for instance, if the nearest appropriate facility is 5 miles away, it will pay any facility up to 10 miles. But if the facility that you went to is 11 miles away, it will deny that last mile during their policy. Now, it could just be a coincidence. Locality is one of those frequently misunderstood issues in Medicare billing. So it could just be a coincidence that WPS is getting on the locality issue at the same time Noridian is reviewing past trips under the SMRC program. It could be that both are taking their cues from the 2015 OIG report, right? Or it could be that CMS has asked them to look into it. One common factor, though, seems to be a lot of these are inter-hospital transports. Now, just to be clear, the locality rule is not intended to apply to inter-hospital transfers. It is intended to apply to 911 trips. What's happening, though, is you're seeing a lot of consolidation in the hospital space. And with that, what you're seeing is larger and larger health systems. And for obvious reasons, those systems want to transfer patients within their network. So they may be bypassing a competitor's hospital with a cath lab to go to their system's hospital with a cath lab, and therefore going either a large number of miles, which might be what's triggering the SMRC audits, or in the WPS setting, in a TPE audit, that's what they're looking for. So, that may be what they're looking at. Lisa just is just reminding me that WPS was challenged via ALJ hearings regarding the application of locality and market share. And many of these were favorable in the early 2010s. Lisa, yep, you are absolutely correct. I participated in many of those. A few things I will point out, though, is since those hearings, CMS has clarified that the MACs have discretion to define locality, and WPS is acting within its discretion. So the issue is not so much challenging the WPS policy as just, at least for these purposes, just pointing out to people that this may be part of a broader, I wouldn't use the word crackdown, but focus by CMS and its contractors on the mileage issues associated with our industry. The TPE audits are the other big compliance issue that's out there. So for those of you that have not had the pleasure, TPE audits are pre-payment reviews that are done in phases. It can be up to 3 rounds. Each round typically consists of them reviewing 20 to 40 claims. Typically, they will focus on a single base rate. So we might look at ALS emergency. Another common one is BLS non-emergencies. They will ask for documentation for each of the claims that are selected. So again, prepayment. So you submit the claim, they will send a development letter. You will send in those claims. They will review them. They will generate an error rate based on their review. So if they review 40 claims and 10 of them are no good, they will come up with an error rate that's about 25%. It may vary based on the mileage, but generally speaking, it will tend to track with the total number of claims. If your error rate is below 20%, congratulations, you passed your audit and you are done with TPE. If you have an error rate higher than 20%, you quote, fail the audit. They will then schedule an educational session with you to discuss their findings. It's educational in name only. And in fairness, even the term discussion implies that both sides get to make points. It will likely be a monologue from them, and they will not listen to anything on your end. And then they will put you in phase 2. And they will repeat the process. If you pass phase 2, great, you're done. If you fail, they will go to round 3. If you fail round 3, in theory, the MAC can elevate it to CMS, and CMS can take additional remedies, up to and including revoking your provider number. So what this means is that the penalties for failing this 3 times can be quite serious. But there is a way to play TPE audits. So just to give you some examples, here's one. This comes from Palmetto, I believe. In this case, they looked at air. So they're looking at A0430 and A0431. That is the base rates for rotor and fixed wing aircraft. They looked at 40 claims. They denied 20. The total dollars involved were $312,000. The total dollars associated with the 20 claims they denied was $154,000. That is an error rate of 49.47%. Therefore, this provider failed and went into the next round of the review. Palmetto's also given some statistics as to how people have done in its results. This is through February of 2020. So they tended to focus on ALS and BLS emergency claims. So they reviewed 235 providers, 198% passed round 1, 37 were subjected to round 2. And then they break it down further by state. And what you're going to see is that, generally speaking, Palmetto applied a fairly lenient standard of review. Most providers passed. I forget what the number is, but 40 out of 240. So let's call it 1 in 6 failed, right? So 5 out of 6 passed. That's probably somewhere in this 80% range, give or take. So they were fairly lenient. There were other providers that have been MACs, excuse me, that were a little more strict, especially when they reviewed BLS non-emergencies. Keep in mind, this predates prior authorization for most of you. And then they give their reasons. So lack of medical necessity is the highest, as you'd expect, in terms of, so 1/5 of all the claims that were denied for medical necessity. 16% were denied because the providers simply failed to respond. 15% resulted in downgrades. Now, we're going to have to talk about the downgrades in a second, but I do want to focus on signatures. Either an illegible patient signature or no patient signature accounted for almost 20% of those denials. These are entirely unforced errors on our part. So you are given advance notice that you'll be subjected to a TPE audit, and yet these providers still chose to submit claims either without a legible patient signature or without any patient signature. That is just asking for a problem, right? So if you know you're subjected to a TPE review, we should be fixing signature problems before we submit the claims. Now, I mentioned I'd come back to the downgrade issue. So Palmetto is owned by Cigna. Cigna in particular really doesn't understand the concept of an emergency response and how it relates to whether or not you're entitled to bill for an emergency. Rather, they are looking at the severity of the patient's actual condition on scene. Now, that on-scene condition goes to whether or not the patient needs an ambulance at all, meaning medical necessity. But if you assume that a claim is medically necessary and therefore covered, then and only then do you get into whether or not you qualify for the ALS or BLS level of service. And then, having made that determination, then and only then do you determine whether or not you're entitled to the higher payment for what is technically a subcategory. So ALS 1 has 2 subcategories: ALS 1 non-emergency, A0426, and ALS 1 emergency, A0427. Cigna is wrapping those 2 up together, looking at the patient on scene and going, maybe they didn't need, it wasn't really life-threatening, and then downgrading emergencies to non-emergencies. On the one hand, they are probably being fairly lenient in their mind to the provider, because in most of these instances, the patient probably didn't require an ambulance. But their analysis is flawed. They should deny the claim outright in that case. but it becomes problematic when the patient clearly did need an ambulance, but the actual reason they called 911 may not have been as serious as they presented on the call, right? I think I'm having a heart attack will generate an immediate response. You get on scene, the patient is not having a heart attack, but they have some minor medical condition that does warrant evaluation at the hospital, and they are bed confined, meaning they have a chronic condition that requires an ambulance. In that case, they would downgrade it to a BLS non-emergency. They shouldn't. It's medically necessary because the patient's bed confined. It's BLS because you're prudent stick an IV in them or place them on a cardiac monitor. It's BLS emergency because you responded immediately, because you were told the patient was having a heart attack, right? But by combining those or conflating those three, they are making it very difficult for certain providers to get off their TPE audits. This will ultimately come to a head when some of these start failing that round 3 and they refer them to CMS. However, CMS has been studying the issue for over a year now. The reality is there is no one at CMS at this point that understands our coverage rules, and therefore there is no one that can call a penalty on CGS. And in CGS's case, their medical director just doesn't understand the coverage rules, and like all doctors, is fairly convinced that he is correct. Couple of questions. So one is that we received a supplemental medical review request from Noridian, and I noticed that a large number of them were emergency ambulance transports for patients that left the hospital without being seen. It is possible that that is another thing they may be looking at. In fact, that's another item that is on those 7 questionable billing practices, was billing for an ambulance trip where they can't find a Medicare covered service at the destination. So it's possible that that is what they're looking at. The only thing I will say is if you are routinely transporting patients in an emergency to the hospital, and those patients are leaving the hospital without being seen, it would cause me to question A, whether it was reasonable to take them to the hospital in the first place, and B, I question how they were able to get home without an ambulance. They were able to get home without an ambulance and they didn't need one to go to the hospital. So, Julie, if that's the case, then I would expect that many of those would be denied. Now, you're welcome to appeal them and make the case, but that would be a major red flag to me, that I have a 911 abuse problem that I may have to handle at the local level. Another question was that during COVID, we often take patient discharges to a SNF that was further away than the closest appropriate facility. Yet the closer appropriate facility was not accepting the patient for various reasons. How would this be handled? David, that's an easy one to handle. If the closer nursing home was not willing to accept the patient, then it was not an appropriate facility, and you would go to the next one. So if the nursing home you were taking them to was the closest one to the hospital that would accept the patient, then it is the closest appropriate facility and all of the mileage would be covered. The one question caveat, though, is it is not uncommon for patients to go back to the hometown from which they are from if they require nursing care. So if it's an initial admit back to a SNF in their hometown, I would question whether or not it is truly the nearest appropriate facility. Can you explain more how the 5-mile radius can expand to a 10-mile radius? So this goes back to the WPS policy. So what WPS is saying is they will pay all of the mileage to take you to the closest appropriate facility. However many, however many miles that may be. They are then saying that in addition, if you bypass the nearest appropriate facility, we will also pay all of the mileage as long as that extra mileage is 5 or fewer miles. So if the nearest appropriate facility is 5 miles away, and you elect to take the patient for whatever reason to a nursing home that is 8 miles away from the hospital you're discharging them from, the nearest appropriate nursing home is 5 miles away. So that is the nearest appropriate facility. 5 miles is covered under all circumstances. What WPS is saying is we will give you a grace period of an additional 5 miles over that 5. By contrast, if the nearest appropriate facility is 10 miles away, WPS is saying they will pay up to 15 miles. So it's not so much that it's expanding, it's WPS is essentially defining locality to be a halo that is 5 miles around whatever the nearest appropriate facility ends up being. I hope that explained it. All right, moving on. So back to the TPE audit thing. So one of the keys to understand is that the way the TPA audit process works essentially creates a game. Lisa, they did use the word locality, just to be clear, in their policy. TPE audits, again, a game that can be won. So first is we have to define what winning looks like in a TPE audit. Winning is not getting every claim paid. Winning is getting off of the TPE audit. So once you understand that, now we get into our tactics, right? Our goal is to have less than a 20% error rate. The one thing we control in a prepayment audit is the universe of claims that are available to be audited. So let's assume you have 100 claims for ALS emergency base rate. And let's assume that 90% of them are excellent, slam dunk, could not possibly be argued. And you have 10 that are sort of wishy-washy. I would argue that it does not make sense to submit those 10 claims now, because they might be picked up in the TPE audit. In fact, let's assume they're the first 10 claims you put in, and let's assume they select all 10 of them. Then you put in 30 of the other 90 slam dunks. They get their audit sample of 40. They review 10 wishy-washy ones and 30 slam dunks, deny all 10 wishy-washy ones, and come up with a 25% error rate. By contrast, if you had put the 10 off to the side, submitted 40 of the 90 slam dunks, they would have selected those 40 first, reviewed them, and you would have ended up with a 0% error rate. In other words, that's how we play the game. Marginal claims do not go into the system during a TPE audit. You put them off to the side until they've developed their sample for that round. Then, if you feel that you have an argument for coverage, you submit them. So we stack the deck, essentially, right? The other thing we need to do is we have to follow through on it. It may mean slowing down cash flow in the short term, but it's well worth it if it gets you off the TPE audit, right? So the mistake I see people make during a TPE audit is they are looking at their own claims with a biased view. I think it's fine. They send it in, and then when it gets denied, they say, this is ridiculous. How could they deny this? And I look at it and go, well, I'm not saying they should have denied it, but here's what I think they're seeing, right? You found the patient in a wheelchair. Yeah, I understand that they have behavioral issues, but they were in a wheelchair. Why couldn't they be transported in a wheelchair van? Well, they might act up. They might try and jump out of the vehicle. And I'd say, you're right. They might do all those things. Therefore, an argument for coverage exists. But is this the strongest possible claim we could have submitted? No, of course not. So if we can move them off to the side and not have them picked up as part of the review, we would be far better off. So, and also, when you fail the first round, we have to adjust, right? The other mistake I see people make is WPS is wrong. Noridian is wrong. They don't know what they're doing. And then when the second sample gets selected, they just submit the same type of claims, right? And then they get the same result. So we've all heard that, saying the definition of insanity is doing the same thing over and over again and hoping for a different result. Two things can be right at once. You can be correct that Noridian is incorrectly denying the claims. That's the first thing. The second thing is you still failed the TPE audit, right? So during the educational sessions, if you fail the first round, I use them as a recon mission. People tend to focus on the claims that got denied. I tend to focus on the claims that got approved by the contractor. Why? Because those are the types of claims I want to feed them going forward. For instance, I can recall one educational session where They had a claim that they paid and a claim that denied. And I asked the MAC, I don't understand. You paid this one, you denied this one. Both of them involved patients with an altered mental status. That was the basis for the argument for coverage. And the reviewer said, right, the one we denied, the patient had a GCS, a Glasgow score of 14. The one we approved, the patient had a Glasgow score of 13. 13 is serious enough to warrant an ambulance, 14 is not. Well, what I just heard is submit claims where the GCS is a 13. Don't submit where the GCS is a 14. Sure enough, we implemented that strategy and that provider got off the TPA audit. So keep that in mind. If you fail round one, you're going to have to change your tactics. We can't say they're wrong, I'm right, and just keep doing it because you will get the same result. Figure out which claims they're willing to pay and then feed as many of those as possible to them in the second round. Put the other claims that you believe should be paid off to the side. Once they've developed their sample, you can safely submit those, right? Keep in mind, you have a year to submit a claim. All right, so turning off Medicare, just real quickly on the VA, they did change a couple of rules recently. So the first is they issued a final rule that would change the payment methodology under their beneficiary travel program. So beneficiary travel is typically travel that's to or from the VA in a non-emergency situation, or to or from a non-VA facility where it's been prior approved by the VA. Under the current rule, those are paid at the provider's full billed charges, because under that program, ambulance is what's called a special mode of transportation. Under the revised methodology, they will now pay the lower of your billed charge or the approved Medicare allowable, and this will kick in on February 16th, 2024. Now, the actual impact on beneficiary travel will be quite low because most beneficiary travel is done by VA contractors and is paid at the contracted rate. Why this has become sort of a big deal is because the VA is unable to distinguish beneficiary travel from travel under its community care program. Community care program is sort of like an umbrella coverage for anything else that is not covered under a more specific VA program. Under the community care program, the VA is supposed to pay claims at the Medicare allowable, but because they can't distinguish them from non-VA claims, from beneficiary travel claims, they treated both as special modes of transportation and paid them at their full billed charges. So in order to eliminate the mistake where they're paying everything at full billed charges, they're going to pay everything at the Medicare allowable. And it is the Medicare fee schedule that is in place for that base rate in your state and zip code. So it will include rural bonuses, et cetera. Although, as you know, with the VA, anything is possible. So don't be shocked if, when this goes into effect next year, there are hiccups in terms of, they're paying them correctly. For instance, it's not unusual for them to pay them based on the Medicare allowable in place in the zip code in which the VA facility is located, not the point of pickup. So the other change is to the Millennium Bill. And here we need a little bit of background. So the Millennium Bill covers emergency treatment in a non-VA facility and any ambulance transportation to that non-VA facility in an emergency. One of the requirements for coverage is that the veteran has to have no health insurance or any other recourse against a third party, like liability, that would pay their bill in whole or in part. The VA interpreted this to mean that coverage was limited to situations where the veteran had no health insurance. In 2020, Congress removed the phrase in whole or in part. And as a result, the VA amended its regulations so that it can now make Millennium Bill payments where there is auto or some other form of non-health insurance that made a partial payment. but they left in place the restriction that partial payment by a healthcare provider or by a health insurance barred payment under the Millennium Bill. So this was problematic when a patient had Medicare Part A that paid their hospital bill, but not Medicare Part B benefits that would have paid their ambulance bill. This is the provision under which they were denying your Millennium Bill claims. So we fast forward and a veteran sues because he's denied Millennium Bill coverage because his health insurance made a partial payment. Now, I don't recall if he had Medicare Part A, but not Part B, but this would be the same situation. The Court of Appeals for Veterans Appeals ruled that the reimbursement bar on health insurance only applies if that health insurance fully extinguished the veteran's liability. So as a result, in 2018, it further revised its regulations to remove the statutory bar for partial payments by healthcare plans. Again, the most likely or the most common situation was veteran has Part A, but not Medicare Part B. That leads us to a second case. And the question is whether or not the deductibles and coinsurance were, quote, similar payments and therefore subject to the bar on reimbursement under the Millennium Bill. I'm not going to get into the detailed analysis here. The basic ruling is deductibles are a payment similar to health insurance and therefore barred under the Millennium Bill, but coinsurance is not, and therefore would be payable under the Millennium Bill. So if the primary health insurance pays the claim and assesses a copayment without a deductible, the VA Millennium Bill cannot pay. The VA cannot pay under the Millennium Bill because copayments are barred by statute. If the primary makes a payment but applies a good portion of that to the patient's deductible, that's similar to health insurance and also is still barred. But if instead the patient's cost share is a coinsurance, and the difference between a copayment and a coinsurance is a copayment is a fixed amount, $50. A coinsurance is a percentage, 20% Medicare coinsurance. Coinsurances can be paid. So if a veteran has Medicare Part B and it pays the ambulance claim, you can still look to the Millennium Bill to pay the patient's Medicare coinsurance. They will now be obligated to pay that. All right, so that takes us to the end of the formal presentation. I believe we ran a little bit long, but I'm happy to stick around in case we have any additional questions. So first one in from Keith. Do I want a Medicare Advantage question? I don't want one, but I'll take it. WellMed, which is of course a UHC plan, is not paying rural, super rural. When appealed, WellMed says talk to UHC. We talk to UHC and they say talk to WellMed. WellMed forces us to argue per claim, not willing to change our basis, super rural suggestions. Keith, yeah, it's a common one. There are really only two options. If you contract with them, you would specifically write it into your contract. In fact, what I would suggest is that the rate actually just be the super rural rate. If you are not contracted with them, you could attempt to contract with them and address it in the contract. The other option is to sue them. Those are the only two options. I realize neither of those may be particularly attractive to you, which is precisely why they're doing it. So generally speaking, in healthcare, at least with ambulance, because we are such a small part of the spending, most of the mistakes that we see by contractors or payers can be attributed to mistakes, ignorance, apathy, right? The caveat or the exception to that general rule is when it's UHC, I don't think it's a mistake. UHC, I think, just is the rules lawyer, if you will, among all of the payers. They look for every little loophole and they play their leverages to maximum advantage. Keith, the other option is, frankly, just to bill them for a denial as non-covered and then bill the patient directly. not for the mileage. You'd have to do that for both the base rate and the mileage. The idea would be if enough patients complain, that will force WellMed back to talk with you, and at that point you can discuss a contract. But ultimately, the solution is going to be a contractual one between you and WellMed. If you are part of the city, I would definitely have your mayor call your congressman and have your congressman call the Department of Insurance, or the mayor to call the Department of Insurance in your state and have them facilitate a discussion between you and WellMed. All right. Seeing no other questions, Megan, I guess I'll turn it back to you. Before I turn it back to Megan, though, I just want to thank everyone. As a reminder, the reference manual will be available for download in the coming days, so be on the lookout for that. Hope to see some of you at our many cost data sessions around the country over the next coming weeks. And with that, thank you again. Megan, all yours.
Awesome. Thank you so much, Brian. And thanks again, everyone, for joining us today. As Brian mentioned, the Medicare Reference Manual will be available probably this evening on our site. It is free to download for members, and the online version, recorded version of the webinar will also be posted probably by tomorrow morning, as well as those PowerPoint slides. So feel free to check out the AAA store to download those items. And as Brian said, the cost collection workshops, that registration is also live, and you'll find that on the AAA website when you click on the store. And with that, I will wish you guys a good afternoon. And thanks again, Brian. And thanks everyone for joining us.
Thank you, everyone.